All right, so the next topic is pathology, respiratory pathology for NMU. As usual, I'll start off with the words to remember. The reason I started off in the beginning is I need to highlight that these words are just general words. You will see these words in lessons, but the problem is if you learn it there, you will associate that only with that lesson. So if you don't know that this is a general word, it won't be in your vocabulary. You will tend to forget it unless you are talking about that lesson. So the first word is consolidation. What does that mean? That means the air in the lungs are replaced by something else. So where there should be air, now we have, let's say, fluid or maybe a solid mass, a tumor is growing. That causes the lung to harden. That region of the lung is hard now. Think of the lung as a sponge, and now it has hardened, so you cannot squeeze it. That area usually cannot get involved in respiration. Next, pneumo. This is a prefix which you add in front of words such as pneumothorax. And what pneumo means, it is associated with air. So I have two examples here. Pneumothorax. So as you know, we have, let me erase this. So we have our lungs, and it is covered by the pleural space, pleural cavity. This is the pleural space. And in pneumothorax, instead of the pleural fluid, you get air accumulated there. You have pleural fluid, but then air is leaking into that region. That is called pneumothorax. What is hemothorax? Again, break down the words. It's air plus blood accumulated in the pleural space. Next is a word which you need to know, which is important even in surgery in all future lessons. This word is called nosocomial. That means hospital acquired. These are diseases where you go to the hospital for something else and you get this type of infection. Nosocomial is a hospital acquired disease, most commonly pneumonia. And these are just some general words, English words. Confluent, that means it flows together or merge. So I will explain this word later. You will understand. But then the disease can spread. So if the disease started off with just this one, it can spread to the other one, and so on. So this is confluent. What is a bulla? It's a large blister. Usually it's blackish color. It's greater than 2 centimeters, and you will hear that a lot in different lessons. Next, when you add the word pan, so pan-acina, pan-coast tumor, that means across, or it goes across or throughout the whole structure. Next, acina. We get that word in two locations in medicine. One, in relation to glands. So these are the cavity which is surrounded by secretory cells. This is the place to which these secretory cells will produce their secretions. So that is what you call acina in terms of glandular epithelia. The other type is the region of lung supplied by a terminal bronchiole. So we have the lung. Let's say this is the terminal bronchiole and the alveolus. And if this is the lung, okay, it won't be this big, it's microscopic, but then this region is called the acinus. Finally, ectasis. That means dilation. Next, I will talk about the anatomy of the anatomy and histology of the respiratory system, because most of you do not remember this, and this is important to understand pathology. So first, we have the trachea. Then we have the bronchus. The bronchioles and the terminal bronchioles, these are called conduction zone. All of these together are called the conduction zone. And these are called the respiratory zone. It's pretty self-explanatory. So in the conduction zone, the function is not gas exchange. It is to allow the air to travel downwards. And in the respiratory zone, you get gas exchange between the respiratory bronchioles or the alveolar sacs and with blood. So we take the structures here. Let me show it. In the trachea, you get a lining of pseudostratified columnar epithelia. These are goblet cells, which I will draw in green, which produces mucus. And these are ciliated. So what do you call these type of cells? It's the same for the bronchus also. So you get pseudostratified columnar ciliated, pseudostratified columnar epithelium. Now it has the general mucosa structure. First you have the basement membrane, and then you have the epithelial layer, and then you have connective tissue, areolar tissue usually, and then what is here in red is smooth muscle cells. And trachea and bronchus is covered by rings of cartilage. This is basic anatomy. So you need to know that. And as you go further inwards, these cells become more cuboidal, and then gradually they become more columnar and gradually become more cuboidal. So there are a type of reserve cells called club cells. Let me use a different color. Club cells. They also start off as columnar cells, but they will become cuboidal cells. So simple columnar the main thing I want you to know is, as you go further, the diffusion distance decreases. So once you come to the alveolar sac, these are just simple squamous epithelia. This is basic histology. And there's two types of pneumocytes. That is, two types of alveolar cells. The first type 1, are the cells involved in gas exchange. So their function is gas exchange across this thin layer into the blood vessels, into the blood capillaries. And then you have another type of epithelial cells called type 2 pneumocytes. These are cuboidal cells, more cuboidal. These can act as regenerative cells. So let's say there is destruction of the alveoli. It is this cell that can divide and form new alveolar structures again. And also its main function is secrete surfactant. So surfactant is involved in decreasing the surface tension of the lung to prevent it from collapsing. So next we have alveolar macrophages. We learned about this in heart in relation to heart failure, because whenever there is going to be edema and blood enters into the alveolar space, these macrophages will break it down. And these are called hemosiderin-ladled macrophages or heart failure cells. You get it in pulmonary edema and in heart failure. And I explained the X-ray, how to read an X-ray. But first, you need to know that the right lung has 3 lobes. The right upper lobe, the right medium lobe, and the right lower lobe. And you can see the clear demarcation. It is separated clearly. But then because of the heart, we have the middle lobe, left middle lobe is replaced by a structure called lingula. And you have the right upper lobe and the right lower lobe. And I need you to know that the trachea. So we have the trachea, that becomes the bronchus, which will. So we have the trachea and we have the bronchus. The bronchi, because it divides into 2 and enters the left lung and the right lung. This is called carina. The bifurcation is called the carina. And you can see that clearly here. Don't worry about these CT images, but then you can see this is the point of bifurcation, where the bronchi breaks down into 2 and enters the 2 lungs. Again, blood supply to the lungs. So we have 2 types of circulation, and if it was just the pulmonary circulation, the lung will not get any oxygenated blood. The lung tissue will die because of this if there is no oxygenated blood coming to it. So you have the pulmonary circulation, which is the pulmonary artery and the pulmonary vein. And next, we have the systemic circulation, bringing oxygenated blood to the lungs. These are bronchial arteries and bronchial veins. So I need you to remember from basic anatomy, the pulmonary vein will carry the oxygenated blood. In systemic circulation, obviously, the bronchial artery carries the oxygenated blood. So the pulmonary artery carries the deoxygenated blood, bronchial veins carry the deoxygenated blood, and then again the lung pleura. The outer pleura is called the parietal pleura. Visceral pleura is the inner one, which is touching the lungs. And just like the pericardium, you can get similar diseases in the lung pleura. And this is the pleural space. This next part, it's important, especially for pathophysiology. So I will talk about that here, but then you will hear these words, Lambert canals or the pores of Kohn, in pathology. So you need to know what these are. These are called collateral ventilation. That means if these are alternative pathways for air to flow through. So the first one is called interbronchiolar, between the bronchioles, between the respiratory bronchioles, between the other bronchioles, you have the first type, interbronchiolar. Next is called Lambert canals, which is a communication between bronchioles and alveoli, Lambert canals, and finally you have these pores of cone which are between alveoli. So you have, it's easy to remember, interbronchiolar. Next you have the Lambert canals which are bronchiole alveoli, and finally you have the pores of cone which are between alveoli. So you need to know this and remember. And next we have the main pathological changes of the lung in lung diseases. So I drew the normal lung like this. These are the alveoli, these are the bronchi. So first I will talk about alveolar filling disease. Now this is what happens in pneumonia. Diseases like pneumonia. So what happens is the alveoli gets filled up, gets consolidated by fluid. The lung has become consolidated by fluids. And the next type is emphysema, in which you get destruction of the walls of the alveoli. So look at this. Now as you can see, the surface area of these exchange, the surface area for exchange has decreased. That is emphysema. I will talk about that later. Next, bronchial obstruction. So now we are talking about the bronchi. There's going to be obstruction here, usually by mucus. And restrictive diseases are diseases in which these walls are thickened or hardened along with the deposition of substances. So the four pathological changes in lung diseases are: you get filling diseases and diseases which decrease the surface area, obstruction of the bronchi, and restrictive diseases. So next I will talk about pneumonia. Pneumonia is what is seen in COVID-19. One of the end stages is pneumonia, which can lead to acute respiratory distress syndrome, and you need to put the patient on a ventilator or the patient can die. So pneumonia, let me tell you a small story. My grandfather, my dad's father, he went to the hospital with fever. So what did the doctors do? They put him on a ventilator. It was unnecessary, but they put him on a ventilator. And what happened was, he got a nosocomial infection from the ventilator, like from the mask. There's a high risk of hospital-acquired infection. And he died of pneumonia. And one thing which actually helps you through that is the fact that it's painless. Like at a certain point, these patients feel no pain, they don't know what is happening, and they die peacefully. But then that was an avoidable death. So I will talk about how you classify pneumonia. See, the thing is, the presentation, the clinical presentation is usually very similar. So how do you differentiate the types? Based on the etiological agent, the causative agent. We have three main types of pneumonia. First is lobar pneumonia. Lobar pneumonia. This is pneumonia, consolidation of the... Okay, let me just tell you in simple terms, what pneumonia is, it is basically an inflammatory reaction in which you get fluid and other inflammatory cells, mainly fluids, coming and blocking up the whole lung. So basically, the lung is filled with fluid. That is what pneumonia is. So in lobar pneumonia, you get the involvement of one entire lobe, or it can involve the whole lung too. And actually, this is seen in organisms such as Streptococcus pneumonia, Legionella, and Klebsiella. If we will talk about Streptococcus pneumonia, what I need you to know is, it is not really dangerous. You can easily treat with antibiotics. So the common cause is aspiration from oropharynx. What is aspiration? You basically have it enter from your oropharynx into the lungs. As you know, lungs are sterile surfaces. Our mucus, the cilia and the mucus, they function. What do these cilia and the mucus do? They will trap any microbe, and with the mucus, the cilia will kind of push it away all the way upwards and send it to the stomach. So that is the normal function of the cilia and the mucus. But then in this disease, there is invasion into the lungs. Usually aspiration from oropharynx will enter the lungs, and if it contains Streptococcus pneumonia, it can lead to lobar pneumonia. This is a type of fibrinous inflammation. That means there is going to be fibrin involved, and it can lead to permanent scarring, which leads to consolidation of the lungs. Again, I said easily treated with antibiotics. And what do you mean by productive cough? You produce cough with sputum. Now I told you, we will learn that for influenza also. When it's a viral infection, usually you get clear mucus. But then when bacteria come on top of that, they start producing productive mucus. You get purulent mucus, where you get a color, yellowish, brown, you get color. Next, lobular, not lobe, now it's lobular pneumonia or bronchopneumonia, same word. That involves the pathway of the bronchus. At the end of it, usually you get the infection. So at the end of this, you get the pneumonia infection, and this is the dangerous one, and it affects younger people, old people, and terminally ill people. That is one reason why we are at less risk of death due to coronavirus, and that's why older people are at a higher risk. So Streptococcus pneumonia, same as above, Staphylococcus aureus, Klebsiella, and Haemophilus influenza. These are causative agents. And I just wanted to emphasize the carina over here, the bifurcation. Again, you get patchy consolidation of the lungs. So you take an X-ray. I will use the X-ray above, and you will see patchy consolidation, like here and there. Sorry. So you get patchy consolidation. These are like shadows which are patchy here and there. In this case, you get febrile fever plus productive cough. It's an infection, you are going to get fever because there is an immune reaction. Productive cough, and this is important. For lobular pneumonia, the pleura are not involved. Look at this. I'll just tell you a way to remember this. What is at the end of these? At the end of the bronchioles, you get alveoli. So these bronchioles will never reach all the way to the this infection does not reach the pleura. Unlike this, in which you can see it will easily reach the pleura. This is just a way for you to remember. So you get pleuritic chest pain in lobar pneumonia. So what does that mean? Okay, so let me begin it again. So in lobar pneumonia, you get pleuritic chest pain. This is a sharp, intense pain you can get. On sudden breathing, you get a sharp chest pain. In bronchopneumonia, the pleura are not involved, so you do not get this. Next, we have interstitial or the atypical type of pneumonia, because it does not involve alveolar spaces. It instead, see, pneumonia is a disease we talk about involving the alveolar spaces. It instead involves the interstitial spaces. And the most common organisms are mycoplasma and chlamydia. Also, you can get it with viral infections. And you will see mononuclear cell invasion. What are these? Cells like macrophages, they go and invade this region. Because in these types, you mainly get neutrophils. It's an acute reaction. Okay, so what is the pathogenesis? How does this process happen? Let's take it. This is a basic inflammatory reaction. So first, you have the alveoli. And let's say you have, this is the blood vessels. I drew the lymph drainage here. So what happens is, you have the bacteria which will come and cause an immune response. There will be an immune response in which you get, first and foremost, remember, fluid. Let me use a bigger. You get fluid accumulation, edema. First comes the fluid, next comes the neutrophils. And the neutrophils will be called by substances released by the alveolar epithelia and by themselves, called IL-8, interleukin 8. It's a neutrophil chemotactic factor. It attracts neutrophils. Now, as you should remember, in inflammation, capillaries dilate and increase permeability. So structures like albumin, proteins like albumin will also enter along with the fluid. So as you can see, this is a mess of inflammation. There's going to be more fluid leaving into the alveolar spaces than fluid entering into the lymph drainage. So then you get consolidation, you get hardening of that area. And what happens over time? There's going to be fibrosis. This is a late stage. So there's going to be fibrosis. And before that happens, we need to talk about the oxygen diffusion across now. Earlier, there was nothing blocking oxygen from entering blood. There was nothing blocking it from entering blood. Now, it's difficult for oxygen to enter the blood. So, therefore, you get hypoxemia and other conditions related to low oxygen in blood. In addition, when this type 2 pneumocytes are unable to release surfactant because of all this other stuff happening around it, what is going to happen is alveoli collapse on exhalation. When surfactant reduces, the surface tension reduces. So the ability to prevent collapse is low. So during exhalation, there is going to be collapse. And in addition, you can see here, the fluid will obviously cause pressure on the alveoli. So I will go over this again. First, you get the inciting factor. Let's say an infection comes and our body detects it and starts an inflammatory reaction. Next, you get edema. First thing, edema with proteins coming in, and then there's going to be neutrophils coming. Neutrophils will come, and then with everything that's happening, the alveoli will get compressed. It will be unable to diffuse oxygen through to the blood, and they can collapse. So that is the pathogenesis of pneumonia. Remember, it's simply like this: fluid accumulation in the alveolar spaces. 4 stages of pneumonia. First, you have hyperemia, increased blood in that region, and edema. You have that in the first 12 to 24 hours. As you can see the large number of blood cells accumulated in the alveolar spaces. Capillaries will dilate and lead to edema. Neutrophils have not come yet. Next, you get red hepatization. This is a red firm structure like the liver, and there's no air now. There's collapsed alveoli and everything, but there's no air. So that region cannot be involved in ventilation. You get hemorrhage. Blood is leaking into the capillary spaces now. Again, I didn't go into that here, but in addition, there will be blood leaking now. More damage. Blood cells will be found leaking here. And then the next stage will be, these blood cells are not supposed to be there. They will die. So you get gray hepatization. When they die because of the iron and other molecules, they will die. Also, they are destroyed by the neutrophils. So you get a state called gray hepatization. This is during the 3rd and the 4th day. The red blood cells die, and because of what it carries, you're going to get this gray-black look. Still, it's hard. It's a consolidated lung. You don't get airflow. You have neutrophil and fibrin accumulation. Fibrin has come now, and now it is either going to fully recover after a week. It can either fully recover, or if, let's say, you are unable to get rid of the infection due to antibiotics abuse. This is a big thing. If you do not take your antibiotics properly, let's say the doctor gives you the antibiotics for a week and you take it for 2 days because your symptoms have gone, then the infection can start again. It might not give you physical signs, but you thought you got rid of it, but it's still remaining. It can grow again. Or if you have a super infection, basically what it says, an infection by a very virulent, a very strong organism, that will lead to the over release of fibrin. You have more fibrin released into the lungs, and decreased. So now it's filled with fibrin. Neutrophils can't come out. Exudates, what has been released into the alveolar spaces, cannot go back in. Therefore, over time, after a week, they will organize and form a non-functional lung that is due to fibrosis. Again, antibiotics abuse. You do not take the antibiotics for the whole duration because you think the infection has gone, but it is not gone. It's still there. So that will need our body to keep fighting. That is going to bring more fibrin, and then once fibrin comes, it is going to block off anything going out or coming back in. That will lead to fibrosis of the lungs and cause a non-functional lung. Next, we have lung abscess. This is something I need you to remember for radiology. So you get it usually after pneumonia, or let's say a foreign body, aspiration of vomit. This is common in alcoholics, and a reason they can die. So you drink too much alcohol, you get passed out on the road, and the vomit is not going to be able to leave your body. It will instead be stuck on the floor, and the vomit cannot leave out. It will instead enter the lungs, and to attack that, there will be an abscess formed. We talked about this in inflammation, and that can be seen as a fluid air interface. Now if you look carefully here, you can see the interface. This is called a fluid air interface or a meniscus. You can clearly see the abscess. I'm teaching you step by step how to read different diseases of the respiratory system in X-rays. Next, we come to chronic obstructive pulmonary diseases. Chronic obstructive pulmonary diseases, it's of two types. First, it is a type irreversible airflow obstruction. That's what it is. Chronic obstructive obstructs airflow. Two types: chronic bronchitis and emphysema. These can occur together, and I need to focus on this again. It's irreversible damage. There is no coming back from that. It is related to air pollution and smoking. Both of these diseases are related to smoking and air pollution. So the first one I'm going to talk about is chronic bronchitis. Now I need you to remember this in this way. Think of it in a flow. Bronchitis is going to involve the bronchi, the large bronchi and the smaller bronchi. Emphysema is going to involve the respiratory zone, the alveolar wall, and the respiratory bronchioles, but then it's talking about alveolar wall destruction. So we'll talk about chronic bronchitis first. What happens in this is there's going to be, okay, this is the normal structure of the bronchi with minus the cilia. So what happens is this normal structure is going to be replaced by more mucus producing cells. In response to the substances of air pollution, there's going to be so much mucus produced that instead of it being a thin layer like this, it is going to be a very thick layer like this. Okay, and there's a way in which you diagnose these patients. You check the mucosal gland thickness. So you take this, these have, what do you mean by bigger? These cells are now bigger. These goblet cells are bigger. They're producing a lot of mucus. And what you do is you take this distance, and you take the distance from the epithelia all the way downwards to the end of the bronchi, to the cartilage. You check this distance, and if this distance is greater than this distance, you diagnose that patient as a chronic bronchitis patient. The other way you do it, without invasive methods is the patient must have persistent cough, mild to moderate cough, and that produces sputum for at least 3 months in 2 consecutive years. So let's say 2018 and 2019. So that patient has had coughing and sputum production continuously for around 6 months each year. This involves the bronchi and the bronchioles, and now there's stasis. This mucus is not getting removed out from the body. You need to cough. You need to cough cough really bad to try to get rid of mucus accumulations if it is not being removed. So in this case, you get bacteria and other infections which can come and create problems. So when it comes to the large airway diseases, there's going to be a mucus plug. This is the mucus plug which is produced, and it is a part of the chronic inflammation. Now, with all of this, there is going to be decrease in expired flow. So the expired air cannot leave the body. That is called small airway disease. Large airway disease, because their main function is sputum mucus production, you get the mucus plug. And because of that, in the smaller airways, there's going to be a decrease in expired airflow. So late stage, you get hypoxemia. Now, how does the ventilated air, oxygenated air enter the lungs? It cannot. It's covered by mucus. It cannot enter the lungs. So you get hypoxemia. But these patients have labored breathing, hypoventilation. This is in relation to carbon dioxide not stimulating, high levels of carbon dioxide not stimulating. Okay, this is not the way you write it. Partial pressure of carbon dioxide not stimulating our medulla to increase ventilation. Our body is not responsive to the carbon dioxide levels, and you get symptoms of right-sided heart failure. Treatment, no cure. Only thing you can do is relieve the symptoms and prevent complications. Next, we have the other disease of COPD, that is emphysema. First, what is that? There is going to be alveolar wall destruction. The alveolar wall is destroyed. That will lead to poor elastic recoil. So during exhalation, the recoil is not done well. It cannot recoil back to its normal size, and it can lead to collapse of that alveoli. Abnormal, again permanent, enlargement of air spaces distal after the terminal bronchioles. So basically in the respiratory bronchioles, and you get destruction of the walls. So look at this. This is the normal bronchi and the alveoli, and the walls are now destroyed. It's one large structure. So you will also get narrowing of the bronchioles. Alveolar surface area decreases. There will be less perfusion. Now, what is alveolar surface area important for? Proper gas exchange. So when the alveolar surface area is high, more oxygen has space to diffuse into blood. Now the surface area is decreased, you don't have that space, so you get less perfusion and therefore less ventilation into the body. Less oxygen is now in the body, What is ventilation? The gas exchange between alveoli and blood. So again, we are going to talk about the types of emphysema. First, you have centri acina emphysema. That involves the respiratory bronchioles. So you get enlargement of the respiratory bronchioles, but then the alveoli are all fine. So this is where it's enlarged. The distal alveoli are spared. The alveoli more distally are spared. More common in smokers. Okay, this is important because the other type is more common in a genetic deficiency. So, pan-acina emphysema. What is that? It involves the whole respiratory bronchioles and the alveoli. So, instead of the surface area being like this, you get very less surface area in this. So pan-acina involves both alveoli, respiratory bronchioles plus alveoli. Okay. This is associated with usually a genetic defect called alpha-1 antitrypsin deficiency. You get this in smokers too, but it is related to this enzyme deficiency, and this involves lower lobes. And this distal acina emphysema, that involves the most distal acini, which is closest to the pleural space. That can lead to destruction of the pleural wall and cause spontaneous pneumothorax. Air in the pleural space. Air can enter here. This involves distal acina emphysema. Like the name says, involves the distal acina. What is acina? The portion that is oxygenated by the respiratory bronchioles and the alveoli. Pathogenesis. How does emphysema happen? This is a deficiency, this is a defect in which the antiproteases. What are antiproteases? They stop the breakdown of proteins. And what are walls made out of? What are our body's main constituent? All structures made out of? Proteins. So the alveoli wall, it prevents the destruction of these walls. Prevents proteases going and destroying this wall. These are antiproteases. They inhibit the proteases. And the type we are concerned with in the lungs is called alpha-1 antitrypsin. So it can be genetic or it can be due to cigarette smoking. Cigarette smoking causes the release of neutrophils and macrophages because there is going to be inflammation of the lungs. There is going to be irritation of the lungs and there will be an inflammatory reaction, and these will produce oxidants and free radicals that will inhibit the alpha-1 antitrypsin in the lungs. That can lead to chronic bronchitis, chronic inflammation of the bronchi, it can be due to chronic bronchitis and repeated infections too. So we have to know something important. Chronic bronchitis is called blue bloaters. Like before it was actually called chronic bronchitis, it was called blue bloaters based on the physical appearance. Why is the patient blue? Due to cyanosis. Cyanosis is hypoxemia. Basically, due to low oxygen in blood, the blood looks more blue. So the patient looks more bluish in color. Reason for hypoxemia is a process called shunting. You will learn that for pathophysiology, so I will not go through this now. Once you learn it, and when you come back to this, you will understand it better. And the reason for the bloating is signs of right heart failure. Now this patient, see, I told you, carbon dioxide retention because the patient is insensitive to it. You get peripheral edema due to right heart failure. This was done. Obesity in the sense they look bloated, and you get wheezing and crackles. Now this emphysema, in emphysema there is an inability to remove the expired air. Like the pressure is not enough to push the expired air out. So what do these patients do? They usually try that, like they pursue their lips, they have pursed lips, and they try to use all the muscles they can to expire the air out. And these over time get a condition called barrel chest. The chest is like expanded like this. They keep doing that, and over time the chest is going to be expanded like this. So in a clinical scenario, you might see these words: barrel chest appearance, pursued lip breathing, and from the attempt, this patient is trying to breathe the air out. That difficulty will make the face reddish color, pink in color. So that's why you call it a pink puffer. Okay, remember that. Blue bloater and pink puffer. Emphysema can lead to symptoms of respiratory failure. So yeah, for today, for this lecture, study these 3 lessons: pneumonia, COPD, bronchitis, and emphysema.